Welcome to the topic Bacterial Infections in the Dermatology module. By the end of this topic, you should be able to define bacterial infections, and here we'll be talking about impetigo and cellulitis, explain the pathophysiology of the diseases, outline the causes and classifications, describe the clinical manifestations of these bacterial infections of the skin, outline the investigations done, discuss the principles of management as well as the complications and prognosis. Let's get started. So before we dive in further, let's understand the definitions of these two infections. The word impetigo comes from the Latin word meaning skin eruption, stemming from the verb impetere, which means attack. Medically, impetigo is a contagious gram-positive bacterial infection of the superficial layers of the epidermis. Cellulitis, on the other hand, can be broken down into the words cell, which is the basic structure of all living organisms, and itis, meaning inflammation. Therefore, cellulitis can be defined as infection of the dermis and subcutaneous fats. Let's discuss normal physiology, beginning with understanding the layers of the skin. Starting with the epidermis, its epithelium is of keratinized stratified squamous type. The epidermis acts as a physical and biological barrier, preventing the penetration of allergens or irritants. The epidermis is further divided into 5 layers, from outside to inside, namely stratum corneum, the absorptive layer, stratum lucidum, only found in thick skin, stratum granulosum, the granular layer, stratum spinosum, the prickle cell layer, and stratum basilae, the germinative layer. Moving deeper, we have the dermis, the inner layer of the skin, which is much thicker than the epidermis, about 1 to 5 millimeters. The function of this layer is to serve as a protection, more like a cushioning to the deeper structures from mechanical injury, providing nourishment to the epidermis and promoting wound healing. Generally, the skin functions as a protective barrier from mechanical, thermal, and other physical injuries such as harmful agents, excessive loss of moisture and protein, as well as harmful effects of UV radiation. The skin also plays a role in thermoregulation by causing alterations to the blood flow via cutaneous vascular bed and helps with sensation. Now, let's discuss the pathophysiology of both impetigo and cellulitis. Primary impetigo occurs when normal skin is affected by direct bacterial invasion, and secondary impetigo occurs as a result of infection at the previous site of the skin wound. Bacterial infection is usually caused by group A beta hemolytic streptococcal bacteria and Staphylococcus aureus. The infection is commonly due to the local production of exfoliative toxins, leading to immune-mediated pathogen clearance. Any breakdown in the skin due to trauma, cuts, insect bites, surgery, atopic dermatitis, burns, and varicella reveals the fibronectin providing access to bacteria leading to infection of the superficial epidermis. There will be proteolytic cleavage of the extracellular domain of desmoglein 1 protein in keratinocytes, which functions to maintain cell adhesion. As a result, there will be lesions, which is known as impetigo. Some of the risk factors of impetigo include overcrowding, poor hygiene, daycare attendance, diabetes, malnutrition, and immunosuppression. Conversely, the bacteria causing cellulitis include Streptococcus pyogenes, Staphylococcus aureus, or coagulase-negative staphylococci. Once again, any breach in the skin due to insect bites, lacerations, fissures, cuts, or puncture wounds will serve as an entry point into the dermis for this bacteria. Here, the bacteria will multiply. Eventually, the organism's virulence overwhelms the host defense mechanism, leading to the release of more cytokines activating the immune response and thus resulting in inflammation, which is known as cellulitis. The causative agents of impetigo depend on whether it is non-bullous impetigo or bullous impetigo. Non-bullous impetigo is caused by group A beta hemolytic streptococcal bacteria and Staphylococcus aureus, and bullous impetigo are caused by coagulase-positive Staphylococcus aureus and MRSA. Cellulitis, on the other hand, is caused by Streptococcus pyogenes, Staphylococcus aureus, or coagulase-negative staphylococci as mentioned previously. When it comes to classifications, impetigo may be divided into non-bullous or impetigo contagiosa and bullous as well as ecthyema. Non-bullous or impetigo contagiosa are vesicles or pustules that coalesce and rupture, after which the purulent exudate will form honey-colored crust, mostly affecting the face and extremities. Bullous impetigo is when small vesicles become flaccid bulla with clear yellow fluid purulent or dark without any erythema and edema or honey crust lesions. Lastly, ecthyema is a deeper tissue form of impetigo, forming a punched-out appearance due to ulcerative lesions penetrating deep into the dermis. Cellulitis is classified according to the Eron or CREST classification based on the patient's presentation and modified Dundee classification based on the presence of sepsis. The severity may be classified into 4 classes. Class 1 is when there are no or well-controlled comorbidities with the patient being systematically well. Patients in Class 2 are either systematically unwell with no uncontrolled comorbidities or systemically well with poorly controlled comorbidities, and this may delay recovery. In Class 3, there may be marked systemic inflammatory responses such as altered mental status and tachycardia or very poorly controlled comorbidities affecting the patient's response to treatment or even having a limb-threatening infection. Lastly, Class 4 patients may be in septic shock or have life-threatening presentations like necrotizing fasciitis, requiring urgent critical care and surgical input. In the modified Dundee classification, Class 1 is when there is no sepsis, comorbidities, and patients have standardized early warning score of less than 4. Additionally, Class 2 is when there is documentation of 1 or more significant comorbidities with no sepsis and a score of less than 4. Conversely, in Class 3, there is sepsis but a score of less than 4, whereas in Class 4, there's both sepsis with a score equal or more than 4. Now here we will discuss the clinical manifestations of impetigo and cellulitis, beginning with the symptoms. Patients with non-bullous impetigo will come in complaining of red sores near their nose or mouth breaks that are leaking pus or fluid and forming a honey-colored scab. They may also complain of itchiness. Patients with bullous impetigo will complain of small vesicles that become sort of a blister filled with clear or yellow fluid which may become purulent or dark. In bullous impetigo, you will notice vesicles with purulent exudate which ruptures forming honey-colored crusts. These have an erythematous base. There are rapid spread and satellite lesion formation seen which usually follow self-inoculation. Additionally, you may notice mild regional lymphadenopathy. In bullous impetigo, you will notice that the vesicles seen are fragile and they may form flaccid bulla which may rupture and ooze yellow fluid. However, patients with cellulitis complain of generalized malaise, fever, pain and are of redness with increasing size. There's also unilateral involvement of their extremities. Moving on to the pathognomonic signs. So in non-bullous impetigo, you will see honey-crusted lesions, whereas in bullous impetigo, you will see scales on the periphery which develops after the bulla ruptures, leaving a thin brown crust on the remaining erosions. In cellulitis, it is crucial to examine for sensation and verify the pulse in the extremity, checking for signs of compartment syndrome, and assessing the signs of inflammation, which should be positive. These signs of inflammation are rubor, which is redness, dola meaning pain, calor meaning heat, and presence of tumor, which basically means swelling. Moving on to the signs, in the case of cellulitis, patients will present with malaise, chills, fever, and signs of toxicity. The affected area will be warm, swollen, and tender, with non-elevated or sharply demarcated borders. You may also notice some regional lymphadenopathy. Alright, so now we will go through the appropriate investigations you need to order when you encounter a patient with suspected impetigo and cellulitis, so you'll be able to diagnose the conditions. For impetigo, it is important to do gram staining, culture and sensitivity to confirm the diagnosis or even if you're suspecting MRSA. A gram-positive cocci in chains indicates Streptococcus pyogenes, meanwhile, gram-positive cocci in clusters indicate Staphylococcus aureus. Next, you would want to do a skin biopsy in the case of refractory infection. An anti-streptolysin O titer would be done, and this is sensitive to throat infections. Tests can also be ordered to assess the severity and associated findings of these conditions. In the case of impetigo, you could order a urine analysis which could identify acute post-streptococcal glomerulonephritis, especially in the case of new onset, there will be edema and hypertension. You could also do a potassium hydroxide wet mount to exclude bullous dermatophyte infection. Lastly, a serum IgM is indicated in recurrent impetigo in patients with negative Staphylococcus aureus carrier status. For cellulitis instead, you will have to do a blood culture in order to identify the causative agent. A full blood count with differential is indicated, and you would expect to see elevated white cell count and neutropenia. For cellulitis, a few tests such as creatinine, bicarbonate, CK and CRP are ordered to rule out sepsis. Generally, for the management of impetigo, you would prescribe topical antibiotics, systemic antibiotics, and topical disinfectants, whereas in cellulitis, prescribing antibiotics targeting streptococcal species is crucial. In more detail, in cases of patients with impetigo, you would prescribe antibiotics such as mupirocin, retapumalin ointment, and fusidic acid. In addition to that, you may also provide topical disinfectants. However, the use of these topical disinfectants such as hexachlorophene is contradictory in some studies which have shown that these topical disinfectants were not useful when it comes to treating impetigo. The medical therapy of cellulitis depends on whether they are non-purulent or purulent. Non-purulent cellulitis would require cephalexin for 5 days, whereas purulent cellulitis you would need to prescribe trimethoprim sulfamethoxazole or Bactrim twice a day for 5 days and cephalexin. Patients need to be hospitalized if there are systemic signs of infection or failed outpatient treatment, or if they are immunocompromised or with rapidly progressing erythema, unable to tolerate oral medications, or have cellulitis overlying or indwelling or near an indwelling medical device. Surgical therapy may be indicated in some cases. Some of the indications include crepitus, circumferential cellulitis, necrotic appearing skin, evolving bulla, rapidly evolving cellulitis, pain, especially severe pain on passive movement, and disproportionately to the physical exam findings. Some of the acute complications of impetigo include post-streptococcal glomerulonephritis and ecthyema, whereas for cellulitis, acute complications are bacteremia and sepsis. In terms of chronic complications, impetigo may lead to septic arthritis, scarlet fever, sepsis, staphylococcus scalded skin syndrome, and meningitis in neonates. Conversely, chronic complications of cellulitis are endocarditis and osteomyelitis. Prognosis-wise, for both impetigo and cellulitis, they are fairly good. In impetigo, the infection heals in 14 to 21 days, and in cellulitis, improvement in the symptoms and signs can be seen within 48 hours after the initiation of appropriate treatment. Now let's summarize what we have covered so far. Impetigo is the infection of superficial layers of the epidermis, and cellulitis is the infection of both dermis and the subcutaneous fat. They occur when there is breach in the skin, allowing bacterial entry and colonization, which ultimately leads to infection. So among the common causative agents for impetigo would be group A beta hemolytic streptococcus, Staphylococcus aureus, coagulase positive group of the Staphylococcus, as well as MRSA, whereby the causative agents of cellulitis are Streptococcus pyogenes, Staphylococcus aureus, and coagulase negative staphylococci. Clinical features of non-bullous impetigo would be honey-crusted lesions, while clinical manifestations of bullous impetigo would be scales on the periphery, developing after the bulla rupture, forming a thin brown crust. Cellulitis, on the other hand, would present with signs of inflammation such as warmth, tenderness, pain, and area of redness. Diagnosis is via clinical exams and blood cultures if indicated. Management-wise, impetigo requires topical antibiotics, systemic antibiotics, and topical disinfectants. And on the other hand, cellulitis require antibiotics against streptococcal species. We have come to the end of this topic. Thank you.